Good day, students. I hope you are all keeping pace with my speed. Welcome to R.A.T.S in Pathology. Now that you are all good diagnosticians, let me see what you say. A 65-year-old male with uncontrolled diabetes was a frequent hospital visitor for medical aid. Suddenly, he developed fever with cough and expectoration, and his X-ray showed. So please observe the X-ray. What is your diagnosis? Discuss the etiopathogenesis, morphology, and differential diagnosis. As I always promised, my target will be UQ. IQ is equal to UQ. There is a corresponding specimen not from the same patient to show the pathology of this lesion. I hope you people will be able to identify it. We shall be describing it later. And now you can be prepared with the answer or structuring your answer. This is the original picture that I had shown earlier, and in this I find that there are areas of opacities. In some areas it is large and it is distributed towards both the lungs. We call it as patchy areas of opacity, meaning consolidation. And we had seen this in a previous class. In this you find that it is uniform. An entire lobe has been affected. So the difference between this. Yes, you are right. So it is a lobar pneumonia and this is a bronchopneumonia. The definition. It is an acute inflammation of the lung parenchyma with patchy areas of consolidation. An acute inflammation of the lung parenchyma, not pleura, with patchy areas of consolidation. And it occurs in patients who have earlier repeated bronchitis, bronchiolitis, etc. Then there is an extremes of age in the patients. It can be a very young child or an old person with reduced immune status. Patient may be having HIV or he may be on immunosuppressive agents. And there can be comorbidity. Comorbidity in the sense other illnesses can be existing, such as diabetes, which we had mentioned in this case. This I will not dwell into, but for a rapid recollection, you people should go through this. There is a loss of the cough reflex, injury to the mucociliary apparatus, any form of bronchial obstruction, and damage to the phagocytosis at the phag end. So any of these can lead to a defect in the defense mechanism. And ultimately you find that there can be the cellular defect also. All of this can lead to a pneumonia. We had seen this earlier. This is only a recapitulation. What are the organisms that cause a bronchopneumonia? It is usually a bacterial etiology. So Staphylococcus, Streptococcus, these are most common. Whereas in a lobar pneumonia, it will be pneumococcus. We had mentioned types 1, 2, and 3 earlier. Haemophilus influenza and Pseudomonas aeruginosa. This is a culprit in any of the hospital bedridden patient. Pseudomonas aeruginosa. We call it as nosocomial infection. And look at this one. at extremes of age. It can be infancy or old age. Cachexia, the patient is starved, debilitated, bedridden. So these can be some predisposing factors. Kindly bear them in mind. Bronchopneumonia. Morphologically, what do you see? Let me forget what is on the left side and see what is here. It is a specimen of a lung which is showing all the pale color are areas of consolidation. And they tend to be slightly elevated. When we cut, you find that this is slightly elevated above the other surface. In some areas, see, they are all coalescing. Coalescing means joining together to form a larger area. And rarely it can involve the entire lobe, mimicking a lobar pneumonia. Now coming back to the morphology, there is a focal consolidated area of inflammation, which is patchy. Usually the basal lobes are more involved because of the dependency. It is about 3 to 4 centimeters elevated above the remaining cut surface. And they can coalesce together to form large, irregular, map-like areas. And when the coalition is too large, it can mimic a lobar pneumonia. The gross picture we had finished and microscopy. Always I tell you people, kindly follow the subheadings. It will take us to the answer. Microscopically, there is a suppurative exudate. You may not be able to understand or visualize. I shall be showing it to you. Suppurative means purulent, pus. And exudate means there is a lot of inflammatory cells that can be seen. Suppurative exudate. It fills the bronchi and the bronchioles. Bronchi and the bronchioles, not the alveoli. And there is also a peribronchial inflammation. Peribronchial surrounding it. And sometimes later on it can undergo organization or fibrosis leading to a residual lesion. These 4 lines alone we shall by heart. I shall be showing them again in the next picture. Look at this. This is a large bronchus over here and the lumen is filled with inflammatory exudate. All the small blue dots are the nuclei and the rest of it is the cytoplasm of the inflammatory cells. And it is not confined to the bronchus. You find that it goes outside also. It is peribronchial in location. So there can be ulceration. So many other things can happen. B is for bronchus. E is for exudate. And another E also, that is exudate. Usually it is a neutrophilic exudate that we see because it is an acute inflammatory lesion. This is a nice picture that I had taken from Illustrated Pathology. Kindly, I would advise you people to go through this book. It is a devoted writing of Viter. And so you find that there is a bronchopneumonia. This is a bronchial tree and it is showing an inflammatory coughing. Blood vessels are congested. And sometimes I find that the inflammation can go to the periphery also. So it is a purulent exudate, we call it as pus. For a comparison, there is a diagram of the lobar pneumonia where the inflammation is restricted to the alveoli, bronchus alveoli. This is the ciliated epithelium which is being destroyed. Again, a comparison. Always, no, by comparing, we'll be able to remember. We had seen this bronchopneumonia earlier, a stage of gray hepatization. You find that the entire lobe is somewhat gray or grayish white and it is solid, liver-like. Whereas in a bronchopneumonia, it is patchy. It is patchy. There is intervening normal tissue. And in some areas, they have coalesced to form larger irregular map-like areas, and C stands for consolidation. Patchy areas of consolidation, here entire lobe is consolidated. This is something that we should remember. I had projected in the earlier class also, but please. In a bronchopneumonia, the patient is debilitated. He has extremes of age. And the organism is not as virulent as in lobar pneumonia. Staphylococcus, streptococcus are common, whereas pneumococcus is more common in lobar pneumonia. And there are patchy areas of peribronchial consolidation. Peribronchial consolidation. The bronchial tree is affected, but it responds. There will be some amount of morbidity. Morbidity in the sense it will cause a damage by crisis. And it falls by crisis. Sometimes you find that there can be complications. Patient is already debilitated, and therefore there will be some residual lesion that can happen. Lung abscess, empyema can occur. When it spreads, there is a lung abscess and there is an empyema. Empyema is pus in the thoracic cage. And these things we have already seen. Something. Pores of corn will help us to understand. There will be a spread of infection from one alveolus to another, and the entire lobe is involved. We have seen all this. So kindly by heart this tabular column. It is mandatory. This tabular column you can use for both lobar pneumonia as well as bronchopneumonia. Again, a wonderful diagram. A lobar pneumonia, you find the entire lobe is involved, and here all the round small circles are the pneumonic areas, pneumonia areas, and they are filled with purulent material. Separated by white area is normal. So this we call as patchy areas of consolidation. A summary of the bronchopneumonia, almost a repetition. Patient is debilitated, extremes of age, organism is not so virulent. The causative organisms are Staphylococcus or Streptococcus. Patchy peribronchial consolidation affects the bronchial tree. The infection responds, but there will be morbidity. Morbidity means damage. Mortality means death. It falls by crisis. And these are the various complications that can occur. And it can spread to other parts of the body. There can be a meningitis, for example, osteomyelitis, infective endocarditis. All these can happen. The question that we usually get is classify pneumonia. So we have seen two main types, the lobar pneumonia and the bronchopneumonia. This is another type of pneumonia, and it is called aspiration pneumonia. I got only the histological picture. This is a alveolar sac, and I am finding multiple cells which are large. This is the nucleus. And when I look at the cytoplasm, it has got a spongy appearance. Spongy appearance. These cells are called foamy macrophages. They are only macrophages, but since they are having a cytoplasm which is foamy, we call them as foamy macrophages. This is what we see in a case of aspiration pneumonia. Now, what causes aspiration pneumonia? It can occur in these people, children. They have got a tendency for swallowing something that can end up in the windpipe or the trachea going into the lungs. Debilitated patients, when they are given any feed, you find that it can go into the lungs. Comatose patients, the same reason. And there is a suppression of the cough reflex. You find that they can land up with aspiration pneumonia. Post anesthesia, when the patient has not completely recovered from the anesthesia, any oral feed can lead to aspiration pneumonia. And the last one is oily nasal drops. Nasal drops we do give for anything. Even the vitamin A and D, the drops can be oily. They can go to the lungs, leading to an aspiration pneumonia. Not a great question, but then if it is asked, if you write this much, it is far more than enough. And if you get an essay question on pneumonia, this has to be included. And one other type of pneumonia is the interstitial pneumonia. Interstitium means in between. So these are all the alveolar sacs. The colorless ones are the alveolar sacs, and in between I am finding a mild thickening, and the dots are the inflammatory cells. Dots are the inflammatory cells. Since it is in between, in the interstitium, it is called interstitial pneumonia. This picture has been taken from A.L. Rosen, a pulmonary pathologist who has done a great deal of study in pulmonary pathology. The common organisms which can cause mycoplasma, this one, interstitial pneumonia will be mycoplasma. Viral pneumonia. Viral, it can be Coxsackie virus types A and B. Of late, COVID, the coronavirus, it can also lead to interstitial pneumonia. That is a thickening. And what do we see microscopically? The infiltrators, lymphocytes and plasma cells. Lymphocytes and plasma cells. One simple way of remembering, bacteria think of neutrophils. Viruses think of lymphocytes and plasma cells. If it is tubercle bacilli, it can be again lymphocytes and plasma cells, along with macrophages. Bacteria alone, it will be neutrophils. So this is what we people are seeing. You find that there is a lobar pneumonia and then a bronchopneumonia. And what have we seen here so far? Until now, the definition of a pneumonia, the classification of a pneumonia, etiology, various organisms, etc. You will have to mention morphology, the difference between a lobar and a bronchopneumonia. What can be the complications? And the specific types people will have to mention. Anything can be asked as a question. These are all the different types of the pneumonia. So it can be an essay question or a short essay. And I hope that you people will be able to easily handle this question. And this is a diagram that you people should draw, or the black and white diagram that I had shown. A lobar pneumonia and a bronchopneumonia. Is it clear? Efkarestu. Vrityastivī.